Good morning, everyone, and thank you so much to IUSTI for inviting me to give this talk today. When I was starting in my career in infectious diseases, I didn't realize that I would become an accidental syphilologist. So this seems to have been what happened. This infection has truly fascinated me and taken up a good chunk of my career. So before I start, I would like to respectfully acknowledge that I'm located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples whose histories, languages, and cultures continue to influence our vibrant community. So just by way of disclosures or disclaimers, I don't really have any disclosures. Except to say that the information, opinions, and views presented in this webinar really reflect mine and not necessarily that of any of my affiliated organizations. And since I work in Edmonton, much of what I am going to share with you today is from Alberta. Last but not least, I did include just a couple of graphic clinical photographs because I always think, that a photograph speaks 1,000 words. So by way of objectives today, I'm going to describe the epidemiology of infectious syphilis in Canada, to discuss some reasons for the observed rises in syphilis cases, and to prevent some possible solutions to the observed rise in cases. So I'm going to start with a historical quote. Desiderius Erasmus was a Dutch philosopher who said in 1520, "If I were asked which is the most destructive of all diseases, I should unhesitatingly reply, it is that which for some years has been raging with impunity. What contagion does thus invade the whole body? So much resist medical art, becomes inoculated so readily, and so cruelly tortures the patient." So I'm going to start with our first question. Which of the following STIs has the highest reported incidence in Canada? So if I could please invite you all to respond. We're not, don't be shy. We're not tracking anybody's responses. This is just to try to make it a little bit interactive. Now, Greg, we didn't give this a trial run. I wasn't sure if you were going to just stop that. Okay, here we go. So excellent. So I'm delighted to see that the majority of you indicated that chlamydia has the highest reported incidence. Of course, of these infections listed here, chlamydia, gonorrhea, and syphilis are nationally reportable, but genital herpes and warts are not. So they aren't reported or tracked officially in any way. I'm interested to see that some of you, though, did say syphilis, and I could certainly understand why you thought that that might be the case. So syphilis, of course, has been around forever. Some famous syphilitics are shown on this slide: James Joyce, Idi Amin, Al Capone, Lenin, Christopher Columbus, Beethoven. And this is just a timeline of some of the important events in the history of syphilis. Probably the first recorded big outbreak of syphilis occurred in Europe in 1495, and there's still ongoing debate about whether Columbus brought it back or whether it was there all along and taken to the New World. And it took several decades really before much progress was made. As you'll see, in 1905, the organism was finally discovered, and the year after, the first serologic test for syphilis by Wasserman, Neisser, and Brock. And I understand that the Wasserman reaction is still being used as the screening test in some parts of the world. In 1943 was probably the most exciting thing to happen in the history of syphilis. Shortly after the discovery of penicillin, Mahoney and colleagues successfully treated 4 patients with syphilis with penicillin. And you would have thought that we had most of the tools at that point to try to control it. But if we fast forward now to 2020, You will have heard that global syphilis rates are rising, and certainly in Alberta, they're the highest that they have been since 1948. So just by way of a quick overview, syphilis, as you know, is caused by the bacterium Treponema pallidum, subspecies pallidum. It is a spirochete, and it is identical in morphology, antigenic properties, and DNA homology to other Treponema pallidum species, which causes yaws, endemic syphilis, and pinta. And this, of course, is very important because syphilis testing is done as part of immigration medical examinations for all newcomers over the age of 15 to Canada. But I can tell you that the vast majority of positive tests that we see are related to one of these so-called non-venereal treponematoses and not due to syphilis. And so I am certainly of the opinion that such screening is of questionable public health importance. So how do we diagnose syphilis? In contrast to gonorrhea and chlamydia, where if you have a positive test, that makes the diagnosis of a new infection, syphilis, unfortunately, is quite difficult and complex. And of course, many people hadn't seen syphilis for many years or ever until a few years ago. So we make a diagnosis of syphilis really using a combination of things. The history, do they have symptoms compatible with syphilis? Epidemiologic exposure, although quite frankly at this point in time, anywhere in the world you are potentially epidemiologically exposed. If you're a member of a risk group, which we'll talk about shortly, if you have typical clinical manifestations, syphilis PCR has become available to us in the last few years and can be used to diagnose early primary lesions of syphilis, and can also be used to test condyloma lata and mucus patches. But of course, the mainstay of syphilis diagnosis remains syphilis serology. And I already mentioned to you the Wasserman reaction as being the first serologic test. So this is just, even when we're using serology, though, what further makes syphilis difficult to diagnose is that there are a number of different test algorithms that are in use across the world. Even in Canada, some places I understand are using traditional algorithms where you start with a non-venereal screening test such as the RPR or the VDRL, followed by one or two treponemal tests. But most parts of the country now are using this algorithm, which is a reverse sequence algorithm. And it starts by using a screening test, the enzyme immunoassay, which typically arises during the primary stage and is then followed automatically in most places by a quantitative RPR or non-treponemal test. And this test, once somebody has been diagnosed with syphilis, is probably the most important test for us to follow the response to treatment, to determine if someone has been successfully treated, and to determine reinfection. In many places, too, a second treponemal test is used as a supplemental or a confirmatory test. I mentioned to you that in 1943, Mahoney and colleagues treated 4 patients with penicillin. So the amazing thing is that syphilis has not developed resistance to penicillin over the years, and it remains the treatment of choice for all adults, actually. The only thing, though, is that a long-acting formulation of benzathine penicillin is required in order to adequately cure syphilis. So I want to just go back in time again to 1998. 1998 is actually the year that I first started working in Alberta with the Provincial Health Office at that time as the STD consultant. And this was shortly after the proceedings of the National STD Consensus meeting were published, where Canada set 2 goals at that time. Number 1, to eliminate infectious syphilis by maintaining the rate at no more than 0.5 per 100,000 population. And second goal, to prevent all cases of endemic congenital syphilis. Unfortunately, the year after, Vancouver announced a heterosexual outbreak of infectious syphilis, with their cases rising from 0.5 to 3.4 per 100,000 by 1999. The year after in Alberta, we also started to see a rise in heterosexual syphilis, and with a parallel rise at that point in cases of early congenital syphilis. And so I had asked Christina Tomas with the Public Health Agency if she could provide me with a slide just showing what has happened to the rates of infectious syphilis since that time in Canada. And you'll see that there has been a slow but steady rise in cases, and just in the last couple of years, a pretty exponential rise in the number of cases of syphilis. Just taking a closer look at that, you'll see that in 2018, there was a 54% increase in cases, and 2019, this is for national data so far, was suggesting at least a 24% increase in that year. So most of you were correct when you answered that chlamydia is in fact the most common notifiable disease in Canada. So this is chlamydia here shown in purple, and you'll see that the infectious syphilis rate here is shown in red. So with chlamydia rates in 2018, more than 20 times that of infectious syphilis. But of course, with epidemiology, it's never that simple. Although the overall rates of chlamydia are the highest in the country, we'll see that the greatest percentage increase has occurred in syphilis. So whereas both gonorrhea and chlamydia are also rising, chlamydia not very much, just a very slight rise, gonorrhea much more so, syphilis has really taken off. Now, if we look at the regional variation in cases as well, if you take a very crude look at these numbers here, it appears that the Northwest Territories and Nunavut have the highest rates. But of course, the rates are very difficult to compare because the population sizes in both of these regions is so small that it artificially inflates the rates in these regions. If we take the Northwest Territories and Nunavut out of the picture, you'll see that by far and away the highest rates are concentrated in the prairie provinces, with Manitoba, Alberta, and Saskatchewan representing the highest rates in the country. If we take a look overall again at all of the cases in Canada, the male rates have always been higher than the female rates, but again, you'll note that the percentage increase is rising higher among females than in males. If we look now at, this is 2019 data now for Canada, you'll note that gay and bisexual men who have sex with men represent about 42% of cases, which now means that in Canada, about 48% of all cases are among heterosexual persons. But of course, again, there are significant differences in whether predominantly heterosexual outbreaks are occurring or GBMSM outbreaks are occurring by region of the country. Very sadly as well, in my mind anyway, we've seen a dramatic increase in early congenital syphilis cases, and you'll see that in 2019, 45 confirmed congenital cases were reported. Now, several provinces, Alberta, Saskatchewan, Manitoba, and Quebec, also have case definitions for probable congenital syphilis cases, and those cases are excluded from this case count here. So, my second question here is, which of the following is not likely to be an explanation for the observed rise in syphilis cases? Is it, number one, syphilis outbreak cycle, and so it doesn't matter what we do, they will continue to rise and fall or come and go? Is it number two, that we have a better screening test for syphilis? Is it number three, Canadians are having more condomless sex? Or is it number four, none of the above? So just give you a few seconds there to answer. Okay, so in this case, we actually have a bit more of a mix of responses here. So people felt that it was unlikely that syphilis outbreaks cycling is an explanation. Very few thought that it was because we have a better screening test for syphilis. About 17% said that Canadians having more condomless sex is not an explanation, and then about 40% none of the above. Okay, so let's take a look at each of those. So interestingly, if you look over extended periods of time, we do see that syphilis outbreaks tend to cycle. And I think this is a really fantastic slide from the United States from 1941 to 1993, showing really impressive cycling. But I think you'll also see that if we look at the overall trend, there is an overall upward trend in these data. So we also took a look at this in Alberta here, and you'll see that we also see that outbreaks tend to cycle. So if we look back to the 1980s, there was a huge outbreak there. And this was a predominantly heterosexual outbreak. And then we've had a couple of other outbreaks since then. And in fact, this one in 2015 did come down, and we're now seeing an even greater rise. Now you'll see here that we had this huge gap because most of the literature that reports the cycling of syphilis outbreaks say that this occurs typically at 10 to 15 year intervals. And I think that most likely we had this extended period because, of course, this was the AIDS era when there was fear about acquiring HIV, and people were practicing safe sex at the time. And then when new drugs became available for HIV and the increasing recognition that this was it wasn't the end of, there wasn't a death sentence anymore to become infected with HIV, that some of this wore off. Now, interestingly, here in Alberta, you'll see that in 2007, we also introduced reverse sequence syphilis screening. So that's where we screened with the enzyme immunoassay first. And in theory at that time, the literature suggested that we would pick up more cases of primary syphilis. And so that's why that was one of the reasons that that test was introduced. There are many other benefits, of course, to the reverse sequence screening. It allows for higher throughput of tests through labs having to process high volume specimens. It is also more specific than a non-treponemal test, but you'll see that our infectious cases, which is shown in the dark black line here, did not increase as a consequence of introducing the test. However, what did increase was the number of cases of non-infectious syphilis, so late-stage syphilis that we hadn't picked up before. So why are we seeing a resurgence of syphilis everywhere? So the first thing I'd like to note is that although syphilis does not discriminate based on age, race, ethnicity, or sexual orientation, there are certain behaviors that increase a person's risk of infection. And so I'd like to start with a case. So this is Phillip, who's a 28-year-old male on HIV pre-exposure prophylaxis. I'm sure that most of you are familiar with HIV pre-exposure prophylaxis, but the continuous use of an HIV medication, tenofovir disoproxil fumarate with emtricitabine, has been shown to reduce the risk of acquisition of HIV by 90% and is a very important biomedical preventative tool in preventing HIV acquisition. So he reports sex with males only since the age of 16, and he reports a 4-week history of a single genital ulcer, which looks like this. And the fact that it is painful could mean simply that he's co-infected with herpes as well. But this is a very classic chancre of primary syphilis. He also reports 10 male sexual partners in the last 6 months, and he mostly meets his partners by using Grindr or Squirt, which are two dating apps. And he uses condoms about 20% of the time for receptive and insertive anal sex, and no condoms for oral sex, and doesn't report any substance use. So that's a fairly typical case that we're seeing certainly among our GBMSM population. And there is, however, significant geographic variation in syphilis among GBMSM in Canada. So these are 2018 national data here, but I don't think that much has changed. But I don't have more up-to-date national data to guide me here. But you'll see that this is the proportion of female cases, and you'll see that the proportion of female cases is lowest in BC, Ontario, Quebec, and the eastern provinces, where the proportion of female cases is the highest, again, in the prairie provinces and in the north. And so what this is pointing out or emphasizing again is that there is significant geographic variation in the predominance of heterosexual or GBMSM syphilis outbreaks across the country. And I think that there are some differences in the explanations. So if we look first of all at cases among GBMSM, I've already alluded to the decline in syphilis cases that we saw in Alberta during the HIV era, the AIDS era, but we now know that U equals U, so undetectable is untransmittable, meaning that HIV-infected persons with an undetectable viral load cannot transmit the infection to others. And what we've seen as a consequence is that our HIV positive GBMSM who are fully suppressed on treatment are tending to engage in condomless sex. And same with HIV pre-exposure prophylaxis. There's a definite correlation in the use of HIV PrEP and the concurrent rise in sexually transmitted infections, including syphilis. In addition to that, the availability of mobile dating apps has made it so much easier to arrange sexual partners. And this is the case for GBMSM as well as for heterosexual persons. So these three things has meant that there's been an increase in the number of sex partners, condomless sex, and the resurgence of STIs, including syphilis. And I'd like to point out that this is not unique to Canada. This is a global phenomenon that's been observed. So what about heterosexual persons then? So I know that, there's obviously overlap. These are intersecting epidemics among GBMSM and heterosexual persons. But again, the predominance by population does vary geographically across Canada, as I pointed out. And I'd like to share with you a case that I saw a few years ago. I think Caroline mentioned that I work at the Royal Alexandra Hospital, which is our inner city hospital in Edmonton, and also sees all of our high-risk pregnancies. So, and I've changed some of the case details here so that there's no question of identifying this lady. But this was a 25-year-old female who came into the hospital in labor. She required an urgent cesarean section. And the infant had profound physical abnormalities. So this is not her baby, but another baby from a few years ago, showing the profound clinical manifestations of congenital syphilis with a massively enlarged liver and spleen. So of course the liver should be up here, the spleen up here, and they're enlarged all the way down to the groin. The baby's got a severe peeling rash and is also severely anemic. And it is only after the mother delivers this infant that both mother and infant are then tested for syphilis and found to be positive. The mother self-identifies as being Indigenous. She reports unstable housing. In fact, was staying at the women's shelter prior to coming in. Reports injecting meth and down. Did not access prenatal care. But interestingly, she reported that she had a genital rash for 1 month, and that's shown here. And you'll see these very superficial, painless ulcers, multiple of them. And interestingly, she had reported this to the shelter and to a provider there, and was told that this was just a rash from the women's shelter. But when we tested this, we did swabs from these ulcers. They were found to be positive by syphilis PCR. So my third question is, what is the risk of transmission of primary syphilis from a pregnant woman to her unborn child? And we'll just give you again a few seconds to go over to respond to that. Okay, interesting. So we've got most people saying about 40%, about half say 50%, another 40% say 100%, and then we've got a few people saying 5 or 25%. You know, and I think that that is an interesting response. So we'll continue here. So the risk of transmission of syphilis in pregnancy depends on both the gestational age as well as the syphilis stage. And if you acquire primary syphilis in the last 4 weeks of pregnancy, you are virtually guaranteed that syphilis will be transmitted to that infant. So it's highly transmissible. And of course, this is in contrast to just about any other infectious disease in pregnancy. For example, the transmission of HIV in an untreated pregnant female is about 25%. Hepatitis C is about 3% or 3 to 8%. And even hepatitis B, the highest risk of transmission if the mother is very infectious is about 60%. So syphilis acquisition in pregnancy is a very risky situation. And the risk of transmission declines with later stage of syphilis and also earlier in pregnancy, which is why our goal for syphilis in pregnancy really should be to identify the infection as soon as possible in pregnancy and to offer treatment at that point. Transmission can occur as early as 9 weeks, but the risk of transmission increases with increasing gestational age. Now, the adverse outcomes can be quite significant with spontaneous abortion, stillbirth, premature delivery, or perinatal death. And the adverse outcome in the neonate can range from the infant seeming to be asymptomatic to multi-system organ involvement, as I showed you. So why is this happening with congenital syphilis? So this is a diagram that I prepared, I think, after spending years thinking about this. Congenital syphilis is really just the tip of the iceberg of a whole host of social problems that we're seeing. And so some of these are described on this slide. I adapted this from a fact content, but I've just added to it. I think perhaps one of the most important things is stigma and discrimination, particularly among our Indigenous people in Canada, with historical trauma and discrimination in healthcare. Geography is also very important. We know that rural and remote residents and also the prairie provinces, which have a significant proportion of Indigenous persons, is also very important. Many people who are in this situation are also affected by substance use, alcohol, tobacco, methamphetamines, lower socioeconomic status, inadequate or no access to prenatal care, mental health issues, and unstable housing. I'd like to just talk a little bit about the intersection between drug use and syphilis, because I feel very strongly, and I know that some of this is just my observations, because interestingly, when I tried to look for hard data to support this, there is none available for Canada. But I can just tell you from my day-to-day work and other reports that this is a very serious issue right now. This intersection between syphilis and stimulant drug use, particularly methamphetamine and cocaine. So from the United States, there is data reporting a significant proportion of syphilis cases occurring in heterosexual persons is due to engaging in illicit drug use. So drug use, especially meth, is associated with multiple or concurrent sexual partners, inconsistent condom use, and exchanging sex for drugs or money. And so what is it about methamphetamines that does this? So methamphetamines decrease inhibition, increases sexual arousal, and impairs judgment. So these three things in combination are just a setup for promoting the rise in syphilis. Here are some other data to show you. The prevalence of meth use in Canada has been increasing in most places actually over time. Now this data is fairly old, from 2014, but you'll see Alberta here was already on the rise, and I can tell you anecdotally over the last few years as well, there's no question that that has increased even further. And in Alberta, in the last couple of years, we've seen 168% rise in emergency department visits related to methamphetamine use. And the number of individuals using this has more than doubled. So here's just some other information to show you here. New people reporting crystal meth use in the prior year reported to Alberta Health Services, and Edmonton is shown here in the yellow and the whole province in the blue. And you'll see between 2011 and 2017, there's been an increase in methamphetamine use across the whole province, and almost, a little over a third of that is occurring in Edmonton. And this is showing you the parallel or concurrent rise in syphilis cases. The green here is in the Edmonton zone, and you'll also see a shift as well from what was predominantly same-sex or GBMSM outbreak in 2015-2016 to now a predominantly heterosexual outbreak in 2018. I thought that this was quite fascinating as well. It turns out that testing the wastewater for methamphetamine is a really good way to compare the use of meth across the country. And you'll see that Edmonton, again, coming out on top. This has led our Chief Medical Officer of Health to declare in 2019 a syphilis outbreak and reporting that we had the highest rate since 1948, with Edmonton really being the epicenter of the syphilis outbreak. So I want to share with you now what is happening with congenital syphilis in Alberta. Since the outbreak started in 2015, there have been 90 infants diagnosed with congenital syphilis, and you'll see that represents 45 cases, and look at this phenomenal rate per 100,000 live births. And so far in 2020, we already have 30 cases, and 20 of those cases have resulted in infant deaths. I want to just point out again that the expected number of cases should be 0. So this really is an unacceptable number of cases. Many of the infections were acquired or diagnosed late in pregnancy, and many social and health challenges for mothers, substance use, violence, corrections, unstable housing, and mental illness. So what are some of the possible solutions? And so I'd like to just share my thoughts on that, I guess. I feel that it is absolutely critical that we have good and timely surveillance in order to guide our interventions. I know that tries to provide us up-to-date information that they can, but they're really limited by the fact that 13 provinces and territories are collecting the data in different ways, and there are significant delays in those data being submitted nationally, and the information that's all being collected as well is also not necessarily available in all provinces. For example, ethnicity is not available from all provinces and territories. And I know that, and I share the concerns about sharing ethnicity because it can seek to further stigmatize or marginalize populations that are already stigmatized or marginalized. But I also feel very strongly that we cannot appropriately target prevention and control in a culturally appropriate way unless we have this information. In addition to that, information is not always available on sexual orientation. And again, in order to appropriately work with community groups and for those community groups to obtain sufficient funding, this information, in my opinion anyway, needs to be more readily available. So what about prevention? I know that all of you know, sadly, there is no vaccine available for syphilis, but I'm hoping that, Caroline, you're going to come through here. Secondary prevention is what we have right now. And thank you to Troy Grennan, who did share with me this abstract from CAR, where they are looking at doxycycline in addition to HIV pre-exposure prophylaxis. So doxycycline is taken 100 milligrams a day in addition to HIV PrEP. And the preliminary results from this study show that doxycycline prophylaxis decreased the incidence of syphilis and chlamydia, with really just a mild increase in GI side effects due to the use of the doxycycline. The second thing I know we need to do is to heighten the awareness of providers, even though you know, these syphilis outbreaks have been going on for several years here in Alberta. I'm still always astonished that some people seem to be blissfully unaware that this is happening. And so I think we need to continue that messaging that this is out there, and that people need to maintain a high index of suspicion and a low threshold for screening for syphilis, especially among those at risk. Improved education and access to testing of those at risk of acquiring infection. So again, just to share with you some examples from Alberta, our province has implemented opt-out testing for STBBI in provincial corrections. So how that works is, as soon as someone is brought into one of our remand centers, they are offered testing for gonorrhea, chlamydia, syphilis, HIV, and hepatitis C, unless they specifically choose not to do so. Our clinics have expanded to evening and weekend clinics. And I think a very, very important and critical intervention has been the development of outreach teams now some 10 or 15 years ago. But of course, all of this has been put on hold because of COVID. And last but not least is actually incentive testing, which is offering a financial or gift card incentive to people for them to have testing. That's been a highly successful intervention in picking up previously unidentified cases and in helping people to come forward to receive testing. Another thing that I wanted to share with you, and I know that this is happening in other parts of the country as well, is expanding the role of community-based organizations, particularly what were previously called AIDS service organizations, whose primary role initially was to support persons living with HIV, and now their role is being expanded to include other sexually transmitted and bloodborne infections, because they already have connections with many of the affected communities and can best help to offer some of that, treat some of that education. I know that we're not the only place that is going to be challenged by resources for STI programs. When we look at our rates, of course, we always want more money, more people, more time to respond. This has always been, and I think will continue to be, an ongoing challenge. But I can tell you that this has become even more of a challenge with COVID-19 pandemic. Staff have voluntarily moved to support pandemic activities, or they've been deployed. Fewer people are coming in, and therefore less STI screening is being done. And we now have, of course, a global shortage of Aptima test kits for gonorrhea and chlamydia testing. And so we're being asked to modify our screening protocols as well. So that's, you know, just something to bear in mind. There are no easy answers to any of this. I think I'd like to spend just a few minutes here talking about the social determinants of health, although I suspect that that's a topic in and of itself. You know, the health effects of intergenerational trauma are profound and significant, with increased suicide attempts, poor mental health status, decline in social cohesion. It affects parenting and attachment styles, increases addiction, and children may be more likely to experience greater abuse, neglect, and household dysfunction, which increases depressive symptoms. There are also many socioeconomic inequalities among Indigenous people in Canada. The prevalence of poor to fair health status is sadly increasing over time, as you'll see here, from 18% in 2001 to 22% in 2012. So besides income itself, we all know that occupational status and educational attainment are very important factors, and there are significant inequalities in these among Indigenous people in Canada. So what can we do about this, I guess? You know, although I certainly don't think that I have any or even some of the answers here, I do feel very, very strongly about the need for basic supports such as stable housing and basic income support and food, and also the importance of using a harm reduction approach to address the intersection of mental health, addictions, and STIs, including syphilis. And I want to share with you over the last few minutes one example from Edmonton of pregnant women, congenital syphilis, and addictions. So in 2005, after we had our first outbreak, during my time anyway, I was out with our outreach team, and you'll see that we started to notice congenital syphilis, something that the province hadn't seen in literally decades. And in those first 2 years, we had 9 babies with congenital syphilis, 6 out of 9 born to First Nations women, 4 out of 9 who did not access prenatal care, and 4 out of 9 who tested negative for syphilis in early pregnancy, but acquired the infection near term. Now, shortly after this, the Edmonton STI clinic, together with the Walmacaulay Health Centre, which is one of our inner city health centres, formed an outreach team. And I have to say that this, the formation of this outreach team has been absolutely critical. This is some of our staff from the early years, because they actually go out into the community to reach people. And this is, I have to say that some of my most life-altering moments were spent going out with our outreach team, particularly one of our nurses at the time. This is a photograph taken by a very talented photographer, Ken Armstrong. But just to give you a picture, I think when it finally hit home to me was she had taken me out one day with her, and we parked on one of our roads here where there kind of high income housing. We walked just a few feet down into the river valley, and there was a tent very similar to this where there was a pregnant woman sleeping there in the winter time. And that led to us finding out that in Edmonton every year, there are approximately 100 women who are pregnant while experiencing homelessness, mental health, and addictions issues. And we looked at reasons for this over the next few years, but perhaps the most important reason was that the women were afraid that children's services would become involved and that they would lose their custody of their child. That was really the major reason. Of course, there are other reasons: extreme guilt about where they were at or what they were doing, fear of stopping drug use, being homeless, previous negative experience with a healthcare provider, lack of knowledge about pregnancy, and the importance of prenatal care. So shortly following that, an outreach program developed, a project called Women in the Shadows, which was funded by the Public Health Agency of Canada with support by my colleague, Dr. Tom Wong at the time. And fortunately, when that program was found to be effective, the HER program, Healthy, Empowered and Resilient program, was established with funding with provincial dollars. But the HER program recognized that we needed a housing program to house pregnant women who were actively using substances. And so we're just coming to the end of a housing initiative called Pregnancy Pathways. So in 2018, this Pregnancy Pathways was the only housing program in the city of Edmonton offering a harm reduction approach to pregnant women who use substances. You'll see that 2/3 self-identify as being Indigenous, but just to quote here, the program provided a sense of safety and the staff provided meaningful supports other than housing, and it addressed some of their needs for social interactions. Harm reduction, of course, did not work for everyone, but it was seen as being beneficial for most people in this program. And I really think that we need to be looking and enhancing initiatives like this. Non-traditional ways of reaching at-risk populations. This is just one example from BC, where people can go online, print off a requisition and get tested for sexually transmitted infections. We're also looking at a couple of point-of-care tests for syphilis in Canada. You're probably aware that no Health Canada approved POCT tests for syphilis exist in Canada, but it is available in many other parts of the world. So there are currently 2 projects in the country. One is in Nunavut and in Nunavik. This is using a dual syphilis test in communities where currently it takes 7 to 21 days to obtain test results. And more recently in Edmonton and northern Alberta, we're evaluating 2 point-of-care tests that provide test results within 5 minutes, both made by Canadian companies. And you'll see that we have a number of locations that are participating currently, including our Remand Center, the Edmonton STI Clinic, 2 of our inner city emergency departments, and 2 First Nations communities. So we have already seen some success where the test result is being used to provide immediate treatment to patients who are coming in for testing. The Alberta syphilis response has also included increasing awareness, expanding, I mentioned to you already, the opt-out testing, and last but not least, collaboration. We need to have collaboration and the enhanced practice of some of our nurses, part of notification nurses who have now been enabled to do testing and treatment, and the work of many other partners. So we're not going to do these questions again. I'll just kind of respond, show you the correct responses here. Which of the following STIs has the highest reported incidence in Canada? It is chlamydia. Which of the following is not likely to be an explanation for the observed rise in cases? Well, it's really that we have a better screening test for syphilis. We do know that syphilis outbreaks do cycle, but as I mentioned to you as well, that's probably only part of the explanation since we're seeing an overall upward rise. And it does appear that Canadians, in addition to other parts of the world, are perhaps having more condomless sex. The risk of transmission of primary syphilis from a pregnant woman to her unborn child is up to 100%. if the woman acquires syphilis in late pregnancy. So I'd like to conclude here that syphilis is back with a vengeance in Canada. Prevention and control will require multi-sectoral involvement and the involvement of communities and populations affected by syphilis in the greater context of health and wellness. So I would like to acknowledge several people for providing me with slides and information. Christina Tomas from the Public Health Agency of Canada, Dr. Milan Raval, who's doing some work with me right now on methamphetamine and syphilis use, Jennifer Greatrix and Carrie Egan from Alberta Health Services, and Troy Grennan and Tessa Lawson-Tattersall for providing the information from BC CDC. So with that, I think we've got a few questions a few minutes left, and I'd be happy to take any questions, Caroline.
Thank you so much, Amy, for that amazing seminar, and just also for all the work you're doing. It was really incredible to hear about that. So we do have some time for questions. If you could ask them via the chat function, and I will read them out to Amy.
Okay, perfect.
And maybe I'll just start with one to get us going while everybody's thinking of a question. What do you expect will happen with rates of syphilis in Canada as a result of the pandemic? Do you think they will increase or decrease?
That's a fascinating question. You know, and I don't think we really know the answer to that. The only thing is I can tell you anecdotally again that in my experience in speaking to patients, there's been a little bit of a decline in their sexual behavior risk factors, but not a whole lot. And certainly based on what we're seeing with syphilis rates and cases so far in Alberta, I'm not at all hopeful that this will have gone down.
Okay, thank you for that. So we have a few questions now from the audience. So from Joanne Dillon, does Amy think that tetracycline prophylaxis will promote increasing or emerging tetracycline resistance?
Yeah.
Especially in CT.
Yeah, no, I mean, that's an excellent question. I suspect it's not likely to promote resistance in chlamydia because really no one's been able to definitely confirm that doxycycline resistance in chlamydia does actually develop. However, I do share people's concerns about the development of resistance and therefore our inability to use doxycycline for a whole host of other conditions. For example, for community-acquired pneumonia, we can expect that we'll see rapid increases in tetracycline resistance among Mycoplasma genitalium. So I'm worried about other conditions for which we currently use doxycycline. So that is a real worry because it's a real workhorse antibiotic for a number of conditions right now.
Thank you. Okay, another question. What mediums for health promotion would you recommend for those who are at highest risk? What are the best ways to connect?
You know, honestly, I don't have the answers. I don't have the answer to that. I really have come to realize, though, over the years that it's really important to ask the affected communities or populations that you're trying to reach to provide their input. I mean, we can only provide the support to develop those things, but not, I don't think that we can actually develop them. And my kids remind me frequently that I don't understand. I don't even use the right language for social media. So I shouldn't even be trying to do that at my age.
I understand. I go through the same thing. Okay, a couple more questions. What are some strategies to reduce stigma towards STIs in Aboriginal peoples that have been implemented in Canada or Alberta?
Mm-hmm. That's very, very difficult to, I don't honestly know the answer to that question either. I was doing a presentation a few days ago at which there were some First Nations elders present, and their comment was that there is so much stigma around syphilis. And it's very interesting because we do observe more stigma around syphilis than we do around HIV now. I have done a few media things for around syphilis, and I'm always asked by journalists if I could find a patient who's willing to talk about syphilis. Well, the answer is never. I can't even think of anyone who isn't completely mortified and embarrassed by this. And so I think that we have a lot of work to do in terms of trying to normalize this in the broader context of sexual health, because there is still a lot of stigma around syphilis, and that will be very difficult to do. And again, for First Nations communities, you know, I think that we have to seek the advice of the communities themselves and how to do it. And one of the things that has been suggested and does seem to work quite well is that you don't actually put up a sign saying, you know, like for example, the communities that we're doing the point of care test project in, they're not really advertising that they're doing this. When they come in for another visit for something else, if they're assessed to be at risk, they're offered the test at the same time, rather than saying, okay, you know, if you want point of care testing for syphilis, come this way. Yeah.
Okay, thank you. And another question, how are you measuring the performance of the 2 point of care tests?
So in a number of different ways. So our primary goal with these point of care tests is to look at the performance in the field, because for both of the test kits, there's only one small field study each. So that is really our primary goal. We actually want to use finger stick whole blood specimens, which as we know with many point of care tests, the sensitivity and the performance falls off with finger prick whole blood versus serum. But we actually wanted to look at the utility as well in providing immediate treatment. So we're going to be looking at a number of things. We're going to be looking at the time from when the point of care test was done as well to when the standard test results come back, the time to treatment if treatment was offered based on the point of care test. So we'll be looking at a number of different things. And although I know it's not really going to provide us with a whole lot of information, we're trying to figure out if this is practical for use in the field, because we did a similar study about 10 years ago with another test kit that was on the market at the time. And unfortunately, that test kit took about 40 minutes to do in the field. And this was just way too much. And so specifically this time when we looked at possible test kits, they had to be short. And so both of these are under 5 minutes. And we want to look at the ease of use as well for the mostly nurses doing the testing, and the acceptability to the patients, although that's a little bit artificial because we are currently offering a financial incentive to participate as well, because it is taking, of course, it is adding time to their standard visit, about half an hour or so to go through the consent process. We had to obtain ethics approval from the Research Ethics Board as well as Health Canada approval. The exciting thing is that both companies are committed to applying for Health Canada approval for these test kits if our study shows that they are effective that they do have good performance in the field.
Okay, so thank you, Amy. We have we'll take one last question. So with COVID, what has happened with the number of STI testing done, increased or decreased? And with the testing done, has the positivity rate increased?
That's a good question. And I know that the testing rates have declined, certainly here in Alberta. Of course, this is not that easy information to come by. In terms of the percentage positivity, I'm not actually sure, but I see that some members from STI services are on our call, so I'm wondering Jennifer, if I could perhaps just ask you to respond to the percentage positivity, or if you had any comments about that for Alberta.
Hi, Amy, it's Greg. There's two Jennifers. I can allow them to talk, but I don't know which one it would be.
Okay. Jennifer Greatrix.
Okay, thank you. I was trying to find the unmute button. Yeah, I'm not sure of that number right off the top of my head. I'd have to go dig into the lab data for that. But just in terms of seeing some of our other STIs that we've been able to monitor with the volume of testing dropping, you know, we are seeing that increase in positivity rate. So I don't have the specific one for syphilis at the top of my hand.
Yeah.
Just from some work that we are doing with the corrections piece, we're just in the middle of an evaluation with a student. And in terms of that positivity rate for the syphilis EIA, it's up nearly 1/3 of the people coming in through corrections are EIA positive, so meaning past or current infection. But we feel like that evidence is really showing us the value of partnering with corrections and how we might be able to move that model into other kinds of areas in Alberta. And as an example, some of the addictions and mental health settings.
Thank you so much, Jennifer, for that extra insight. And with that, we've come to the end of our webinar today. And I would like to thank Amy for just an absolutely wonderful and informative seminar. Thank you very much for joining us today. And I'd like to thank everybody else in the audience for joining us as well. And again, if you are interested in joining IUCD Canada, please do so. There should be a link to a survey after the completion of this webinar. Thank you, everybody.
Just one last thing, Caroline, is that if people have questions, I'm going to just put up my email in the chat. Please don't hesitate to reach out, and I'm happy to respond.
Perfect. Thank you so much, Amy.
Right. Thank you so much.
Take care, everybody.
Bye-bye.